Assalamu alaikum wa rahmatullah. Good afternoon, everyone. Thank you very much, Dr. Khalid, Dr. Omar, for the nice introduction and words. So today we're going to talk about an option beyond vaccination for certain population, immunocompromised patients. And this session is sponsored by AstraZeneca. So let's talk about COVID, SARS-CoV-2. So if you think SARS-CoV-2 is bad and the situation was really tragedy, think twice, because in about 104 years ago or 5 years ago, there was what we call the Spanish flu. That Spanish flu hit the whole globe, affecting more than 100 million people, 500 million people, and out of those, 50 million people died out of this influenza pandemic. In this wave of SARS-CoV-2, we had more than 690 million people affected by this virus, and around 1 to 2%, 90 million people, so 6,890,000 people died. So I'm going to start my talk with this case. A 70-year-old male patient with malignant lymphoma. He is on rituximab. Vaccinated with two messenger RNA Pfizer vaccine. This patient presented with cough and worsening shortness of breath for more than 7 days. Upon admission, patient was tachypnic with low oxygen saturation, 91%. Chest X-ray revealed bilateral pleural effusion and bibasilar opacities. So admitted to the hospital, given all the treatment we give for severe COVID. You know, we defined severe COVID if your oxygen saturation is 94% or lower in room air, or you have extensive bilateral involvement of the lung by chest X-ray or CT, or you are tachypnic beyond 30 breaths per minute. So this patient received steroids as per the guidelines, antiviral, remdesivir, and then we had to give him Tixagevimab, interleukin-6 antagonist. But even with all that, patient continued to deteriorate, hypotensive, hypoxic, and he needed to be intubated, put on vasopressors. Then we did a chest CT, and now we have worsening pneumonia on top of the COVID pneumonia. And this patient developed ventilator-associated pneumonia. His sputum culture grew XDR bacteria, Pseudomonas and ESBL positive Klebsiella. We had to put him on amikacin and ceftolozane tazobactam. Despite all the efforts we did, patient developed renal failure, went into hemodialysis, and then unfortunately expired. The question we have to ask ourselves, could this have been prevented? This patient was vaccinated, correct? But even though he wasn't fully protected, is there anything to offer this patient beyond the vaccine only? The answer will come later on, but the answer is yes, with the EvoShield. You have to know that 2% of the whole patients you will see in your practice are immunocompromised. Whether it's a disease or a medicine we give, whether it's a transplant patient, malignancy, but keep in mind the medication we give, the immunosuppressive therapy, plays a big role here in those 2% population. And why I'm referring to those, because on those people, the immunocompromised, the vaccine, the COVID vaccine will not be enough. We have to put in mind that we need to give them the vaccine and a second layer of protection. And what do we have so far is the EvoShield. If you compare the immunocompromised patient to the control when they get the vaccine, especially with the messenger RNA vaccination, you will see that the response when it comes to antibody is less. So even if you give 2 doses or 3 doses, your immunocompromised patients are still not responsive as immunocompetent patients. Simply because when you give the vaccine, you rely on the immune system to mount antibodies, correct? But what if the factory itself is deficient, not working very well? So we give the vaccine. In a normal person with intact immune system, you give antibody. This immune system will start to generate antibody, and it will stay in case this patient encounter or the immune system encounter this virus. But if my factory, the system in my body generates antibody is already weakened, very weak by either the disease or the medication, it will not generate enough antibody, and when you encounter the disease, it will be a severe disease. In this study, they noticed that among the patients, all patients in the US, with the 2.7% were immunocompromised, and about 23% of those, whenever they get the COVID, they will be admitted. And this will have an impact, financial impact on the system. Even if you get admitted to normal ward, not ICU, it costs a lot, triple that amount when you go to the ICU. And if you break down those 2.7% immunocompromised patient, you will see that the majority, about 1.5%, immunocompromised because of the medicine we give them to treat another disease, whether it's rheumatoid arthritis, lupus, or even any kind of inflammatory disease. This study done again, and it showed that in England, in certain time, 82% got COVID. Out of those 21% hospitalized, out of those who were hospitalized, 21% were immunocompromised. Out of those ended up in the ICU, 28% immunocompromised. Out of those who died, again, 23% immunocompromised. We have to keep in mind, immunocompromised means high risk for admission, for severe disease, ICU admission, and unfortunately, mortality and death. And if you break down those categories, you will see that hospitalization risk is 10 times or 11 times when you have secondary immune deficiency, let alone cancer, transplant. All those immunocompromising condition or treatments will lead to one outcome: severe disease, admission, ICU, and sometimes death. Now back to the question, could this have been prevented? Yes. We have a medicine, it's a monoclonal antibody called Evusheld. It's a mixture of 2 monoclonal antibodies, Tixagevimab and Cilgavimab. And it has been approved in the UAE for patients who are immunocompromised that we know they will not benefit from the vaccine. So you give the vaccine and this monoclonal antibody, and for those people who cannot get the vaccine for any reason, severe allergic reaction, they refuse, but immunocompromised, or someone cannot get the vaccine. You have to be 12 years old and above and 40 kilograms and above, and it is enough to protect you for at least 6 months, so we give it every 6 months. Now, let's go to the real-world data. Now we have a variants of concern. We know the Omicron has more aggressive variants or subvariants, and those can be less responsive to some medications. So what do we know when it comes to Omicron? This study was done on almost 5,000 patients, 5,135, mainly to see what's the effect of the Evusheld, this monoclonal antibody, on those immunocompromised patients. And look at those immunocompromised patients, you'll see whether it's a disease like lymphoma, multiple myeloma, or a solid organ transplant, or they're taking rituximab. the anti-CD20 treatment. In this study, around 83% of those received the monoclonal antibody, the EvoShield, 16% did not. And what we found, the one received the EvoShield had 50% less likely to have any kind of disease, no COVID. 92% prevention from severe disease, which means hospital admission, ICU. And in this study, if you compare the two arms, EvoShield versus no EvoShield, in the EvoShield arm, no death, zero, no one died. Patients who are immunocompromised and never received EvoShield, they died, some of them. Another study in the VA hospitals, Veteran Affairs in the US, the same concept, EvoShield versus no EvoShield. And again, you can see the upper, I don't know if you can see this. It doesn't work, okay. So the upper, the line showed that patients, the upper one, who haven't received EvoShield or did not receive EvoShield had higher hospital admission, ICU, and death compared to the one received EvoShield. Again, it's protective against severe disease, ICU admission, and death. And what about patients receiving Rituximab? There's a small study number, like only 43%, but it's really impressive. This population, as you can see, they have they have rheumatoid arthritis or ANCA-related vasculitis on multiple different immunosuppressive therapy or immunomodulators. And guess what? All of them were vaccinated. The vast majority got 3 vaccines, messenger RNA vaccine, 81%, 12% got 2 vaccines, 7% 1 vaccine. Did this EvoShield monoclonal antibody help? Yes. In this study, on those patients received this massive immunosuppressive therapy, Rituximab, it helped. So 97% did not have any disease. When I say no disease, even a simple common cold. I'm not referring to a severe disease with shortness of breath and hypoxemia. One patient only, one patient out of this 43 patients severely immunocompromised got COVID and it was mild disease. Now, what about our local data? And this is in Saha, in Abu Dhabi, UAE. You know, there was some in vitro studies showing that EvoShield doesn't work in vitro. In the US, for example, they got the new variants and they checked the efficacy of monoclonal antibodies, including EvoShield, in lab, in vitro. So they got the virus, they mix it with the monoclonal antibody, say if it's effective or not. So in vitro, only in lab, they said it doesn't work. So we decided to check it ourselves in Saha. We have more than 500 patients. Almost half of them, 230, received EvoShield versus the rest of them, 253 no EvoShield, or 256. And guess what? The one got EvoShield. We had 10 cases of COVID out of 230. Out of those, only 2 needed to be admitted, but just for observation. None of them had hypoxemia. None of them had severe disease. None of them went to the ICU. Of course, none of them died. In the other arm, those patients who did not receive the EvoShield, we have cases went to the ICU and became hypoxic. Of course, no one died in the both arms because right away we take good care of them. But someone goes to the ICU, this comes with a price. You have long-term side effects. You cannot prevent long COVID on those patients, in the ICU patients, money spent on them in the ICU. So this could have been prevented by EvoShield. So the bottom line, we know in real life, and that's why I like real life data, better than in vitro studies. It showed that it's still working. And it's very efficacious in who? In highly immunocompromised patients. Now, I'm going to have another 5 minutes talking about the mutations and in this virus. So viruses mutate all the time. It's a normal phenomenon. So if you have a virus replicating in millions of copies, every now and then you will have a defective copy. It's like you having a Xerox machine, copying machine, and it's producing, let's say, thousands of copies. It's normal that every maybe 100 copies you'll have a defective copy. This copy might be a bad one or a good one, virulent, very pathogenic, or nothing. But it happens. This is the normal life circle of the viruses. How do we come out with those names? You started with the Wuhan strain, we call the wild strain, the first SARS-CoV-2. And then we have branches of the virus, alpha, beta, till we reached Omicron with the different subvariants. And when you go to those variants, we are concerned about three things. Why? Virulence, how bad a disease it can give or produce, how fast it can be transmitted, like, is it very contagious or not? And finally, does it evade immunity? If I receive a vaccine and then exposed to, let's say, Omicron variant, can I get the disease? If I was infected, can I get reinfected again? Does it evade the immunity? That's why we have to know the following. The first original Wuhan, each person can infect 2 to 4. Then we ended up with Delta. One person can infect 5 to 8. Now for Omicron, double this. So each person can infect up to 10 to 16 people. See the difference? Very highly transmissible. When it comes to severity in immunocompetent, again, immunocompetent people, no increased severity. We know that the EvoShield, those molecules, is still having efficacy against Omicron, and we've proven that in our real-world data. Now, we have a lot in the pipeline. I'm not a company member, so I can't talk about that, but I know they have a second generation of those monoclonal antibody coming soon, more efficacious. They have vaccines coming, and they're trying to mix flu, RSV, and COVID in one shot annual vaccine. Imagine. They have something to prevent and treat bacterial infection using the monoclonal antibody technology, even for vaccines such as herpes zoster. So in clinical practice, if you're going to evaluate a patient and see how immunocompromised he is or how high risk he is representing, you have to look at three things. Number one, age. Anyone above the age of 60 or 65 will be high risk. That's why you start with with blue, and the higher you are in your age, the more risk you represent. Then medical condition. If you have someone with lung disease, heart disease, kidney disease, liver disease, or cancer, immunosuppressive cancer, or any other condition or comorbidity, then he is at high risk. The more comorbidities you accumulate, the higher the risk. What about vaccination status? The same thing. But this again apply for immunocompetent. I don't have any immunocompromising condition, alhamdulillah, but this maybe applies to me. But I have received four vaccines for COVID. I think I'm fully protected. But if I haven't received any vaccine, I'll be in the red zone, high risk. But if I am immunocompromised, this not enough. Remember, always for immunocompromised, you have to give the vaccine and something else to protect. And what do we have for COVID? We have EvoShield. Finally, immunosuppression. The more immunosuppression you have, the higher the risk. Now, what do we have for this COVID infection? We have prevention, we have treatment, and this treatment goes to 2 stages. So as prophylaxis, as pre-symptomatic, we have 2 things. We have the vaccine, and we have the EvoShield, the Tixagevimab, Cilgavimab. Once you get infected and you have normal oxygenation, we can give either some monoclonal antibody also or antivirals. You have remdesivir IV or Paxlovid or molnupiravir. You have many options. But as prophylaxis, prophylaxis. You are completely with no infection. So I'm giving you something prior to infection to prevent you. I'm giving you vaccine, I'm giving you EvoShield. In case, in the future, you encounter the virus, you are protected. Once you advance in the disease and you became hypoxic, then we have to add steroids and other immunomodulators, and maybe we can add interleukin-6 antagonist. And finally, you might end up in ventilator, ECMO, and God forbid, death. So we have stages, as you can see. Now, who will benefit from this monoclonal antibody, the EvoShield? All subspecialties that deal with immunocompromised patients, or giving a treatment that will cause immunosuppression. And rheumatology is one of them, of course, hem-onc, dermatology, nephrology. Dialysis patients are at big risk. Neurology, for example, multiple sclerosis, we give immunosuppressive therapy. Gastroenterology, we give immunosuppressive therapy for ulcerative colitis or Crohn's disease, correct? Transplant patients, HIV, I deal with a lot of HIV patients. They have to get it. And for rheumatology, certain medications you have to keep in mind that will have high impact on your immunity. Rituximab comes always number one because its deep effect on B cell suppression, and every rheumatologist knows that. Steroids, high dose of steroids, you give more than 20 milligrams for more than 2 weeks, or this is considered to be immunosuppressive therapy. So 20 milligram for 2 weeks or more. Mycophenolate, cyclophosphamide, all those immunomodulators, interleukin-6 antagonists, JAK inhibitors, all of them considered immunosuppressive therapy. And what do I have to do? What I do in SKMC in Abu Dhabi, we have an EvoShield clinic. We used to have it 5 days, now down to 3 days, but we're going to increase it again. And it's managed by IM. And I'm there all the time for them if they have any help. And my advice is to dedicate in your hospital a separate clinic for EvoShield. I have the capacity to do it 3 times a week or 5 times a week. Maybe yours in your hospital or in your facility, you have the ability to do it only once a week. Okay. Dedicate someone for EvoShield clinic once a week or twice a week. But the bottom line, we have to protect our immunocompromised patients. Thank you very much. I'm ready for any question.